about substance abuse treatment, and specifically some information about how clinical psychology can be involved in substance abuse treatment. So a little bit of background. The DSM-4 had 2 substance use disorders. The first one would be substance abuse, which was kind of a milder form of substance use disorder. And substance abuse basically said that someone had had some sort of a problem with drugs or alcohol, but that problem didn't rise to the level of an addiction or a dependence. And then, of course, substance dependence was a more serious category. And basically, substance dependence meant that a person had 3 or more symptoms of more serious involvement with drugs and alcohol, drugs or alcohol. Those 2 diagnoses have now been combined into one category called substance use disorder in the DSM-5. Here are some of the diagnostic, or actually all of the diagnostic criteria for substance use disorder in the DSM-5. One of the criteria is that the individual that's being examined or being assessed would have had a tendency to have either a greater amount would have had a tendency to use a greater amount of substances or to use substances for a longer time than planned. So an example of this would be someone who says, I'm just going to go to the bar and have 1 beer with my friend. They have 15 beers and they stay at the bar until the middle of the night when maybe they plan to be home early that night. So somebody where the amount or the time spent with the substance is kind of out of control. A second criterion would be worrying about cutting down or stopping or unsuccessful efforts to control the use of substances. So I used to joke with the people that I worked with, this was the field that I worked in, and I used to say to them, if you're worried about your drinking, that's often a sign that there's a problem there. And I'd make jokes and say, well, if you're talking about eating peanut butter and jelly sandwiches, you wouldn't really worry about that. That's not a problem, and it's not something that people really spend a lot of time worrying about. But if you're trying to stop eating or stop doing drugs or stop drinking alcohol, or you're worried that maybe you need to, that's often one of the first signs that there's a problem there. And so that, although that sounds a little bit odd sometimes, that concern can actually be a symptom. A third criterion would be that a large amount of time is spent using, recovering from, or obtaining the substance. And here, this is just sort of a classic symptom of alcoholism or drug abuse. Here you'd see people who might spend hours finding the drug, obtaining the drug, taking the drug home, using it, and then recovering from it, recovering from the high, the hangover with alcohol, that sort of thing. For example, some of the heroin users I used to work with they would frequently drive to another city in another state, and it was about 2 hours each way to get to the city. So every few days they were spending, say, 4 hours of driving time, and then usually a little bit more time until they found the person that had the drugs. So a good part of a number of days each week obtaining the drug that they wanted to use. Another criterion would be failure to fulfill major obligations. So this would be you're not taking care of your job at work, you're not taking care of things around your home, you're neglecting your schoolwork, or other things of that nature. Maybe you're neglecting relationships. If there's something important that you're not doing because of the substance abuse or the substance use, that's often a sign that you'd have a disorder. A similar criterion would be giving up recreational activities or hobbies. Just an example is one of the boys that I used to work with who had a substance use disorder. He had been one of the top basketball players in the state, had been invited to a special camp by Nike Athletic Footwear, and they only invited, say, the top 40 basketball players in each state, and this boy had been one of them. But he gave that up because of drug and alcohol use, and he was also involved in selling drugs on the street. Some more criteria listed here. Another one would be craving. This is just an intense desire or an intense urge to use the drug, and that's a symptom that there's a problem. using the drug or using a continued use of alcohol despite problems caused by or worsened by the use of the drug or alcohol. And these could be mental or physical health problems. For example, with alcohol, people sometimes get a disease called cirrhosis of the liver, which is really, it can be a terminal disease. If your liver doesn't work, you're going to die. And so people who know they have liver problems but continue to drink, that would be an example of using despite problems. The problems wouldn't have to be mental or physical health, though. They could also be relationship problems. So if a man is arguing with his wife quite a bit and she wants him to quit drinking and he keeps doing it, that would also be used despite problems. Recurrent use in dangerous situations. If you have a dangerous job and you're going to work high all the time and making a dangerous situation even more dangerous, that's a symptom. This could be somebody like a heavy equipment operator, an electrician. If you touch the wrong wires and you electrocute yourself, that's dangerous. And so you don't want to be high while you're doing that job. So people who are putting themselves in dangerous situations while drinking, while using drugs, that could also be a symptom. And these situations wouldn't have to be on the job. This could be driving a car. It could be, doing something around the house. But anything dangerous that would be exacerbated by drug use where the person continues to do that, that would be a symptom, or it could be a symptom of substance use disorder. Another symptom is what we call tolerance, and this is where we either need more of the drug to get the same effect that we used to get, or we get less of an effect if we take the same amount of the drug. So, for example, the person who maybe gets drunk for the first time when they drank 3 or 4 beers, when all of a sudden they need 10 or 12, over time, they need 10 or 12 to get that same effect. That's tolerance. They build up a tolerance to the alcohol use. One of the most severe cases of tolerance at a very young age that I heard of was that there was a boy that came to our treatment facility, and he was a tiny, small boy, only about 15 or 16 years old. But when the police picked him up, his blood alcohol level was something like 0.3. Well, in the U.S., 0.08 is considered legally drunk. And actually, in a lot of Europe, I think it's 0.02. And so this person was over 10 times, actually 15 times the legal limit where most of you are from. And so, quite a great amount of tolerance just for your body to be able to handle that much alcohol and not pass out or black out. Another symptom would be withdrawal, and this would be getting sick when you don't have the drug or the alcohol in your system. An example of this, a woman I worked with, an older woman, would tell me that she was so sick in the mornings. When she woke up, she hadn't had alcohol yet. She would kind of drag herself to the bar, and the bartender would put a straw in her beer because she was too sick and too weak to be able to pick the beer up and drink it. So that'd be an example of withdrawal. Withdrawal symptoms can be very serious for alcoholics. With other drugs like narcotics, opioids, heroin, things like that, people will feel terrible and they'll feel like they're going to die. But unless they have some other sort of medical symptoms, a heart problem, unless they're very dehydrated or malnourished, they're usually not going to have medical danger due to withdrawal. They'll just feel terrible for a while. They'll feel like they're going to die. Okay, so there were 11 criteria that I just mentioned. When we're diagnosing people, what we do is we look at a 12-month time frame, and we say if they have 2 or 3 of those symptoms within a 12-month time frame, they'd have a mild substance use disorder. 4 or 5 symptoms would be moderate substance use disorder, and severe substance use disorder would be 6 or more symptoms in that 12-month time frame. Just a little bit of information about the prevalence of drug and alcohol use worldwide. I wanted to make a note here too. I'm saying drug or alcohol. The proper term that a lot of people use is AOD, alcohol and other drugs. That gives the impression, or that makes the statement that alcohol is a drug, which it clearly is. In this case, I'm just kind of using the term drug to mean any drug that's not alcohol, just for the sake of simplicity during this PowerPoint. So a couple of things we know. Right now, drug use in the last few years has been pretty stable worldwide. So there aren't more people using drugs apart from alcohol than there used to be. And there's actually been a decrease in intravenous drug users and people that are injecting drugs into their veins. And this is a good thing because IV drug users often pass diseases like HIV/AIDS, hepatitis B and C. And so for public health reasons, even if people are using the same amount of drugs, even if drug use is stable, if that use of IV drugs is going down, that's actually a very good thing. One thing that has been increasing to kind of take the place of the decrease in the IV drugs is that there are some new psychoactive substances. An example of these would be some chemicals that are being sold in the US as bath salts, things that you would dissolve in the bath. They're really not bath salts at all. They wouldn't work that way. They're actually chemicals that give an amphetamine-like high. But because there haven't been laws passed yet in a lot of states, or there weren't until recently, there weren't laws that regulated these chemicals because they were new chemicals, they could be sold legally in the US. And instead of selling them as drugs that will get you high, because of course then people will protest the stores are selling them, they would be sold in small plastic bags and sold as bath salts. And so people could legally buy these things in stores, and these were often sold in sort of the small convenience stores, and that's an example of a new psychoactive substance. There were some other things too. There were some artificial cannabinoids, sort of like artificial marijuana products that were sort of herbs that had this artificial cannabinoid sprayed on them, and then they were smoked, and they were sold as potpourri or incense, things like that. They went under names like K2 and Spice. So those are some of the substances that are newer, that are harder to regulate in the U.S. That sometimes can make it hard for law enforcement officials and court officials to really regulate them, because it's so hard for them to stay on top of what substances people are abusing. So when these new substances become popular, it takes a while for the laws to catch up and to ban these substances. And so for a while, they can actually be sold legally. I should also mention that right now, alcohol is the most abused drug in the world. And alcohol use is especially high in the former Soviet Union. The World Health Organization says that about 10 liters of pure alcohol, of ethanol, per person per year for a country would be high consumption. In many parts of the former Soviet Union, the consumption is actually 150% of what the World Health Organization designates as high. So some countries in that very high range, 150% or higher, would be Lithuania, Ukraine, Russia. Right now, Moldova has actually the highest rate. They're at almost 200% of what the World Health Organization designates as high alcohol use. And so a lot of the former Soviet countries are among the leading countries in the world in terms of alcohol consumption. I wanted to tell you a little bit about substance abuse treatment. This will be the focus of most of the rest of the lecture. In the US, we have what's called a continuum of care, and that just means that there's all different levels of care that a person could have in the course of treating a substance abuse disorder. And so the lowest level of care would be what's called outpatient therapy, and this is where a person goes to an office that's not in a hospital, so they're not inpatient, they're outpatient. And they usually just go for one session a week, maybe an hour, hour and a half of therapy per week. The next step up, a little bit more intense, would be what's called intensive outpatient. And this treatment would take place usually somewhere between 1 to 4 hours per week. So the person might go for, say, one group therapy session that would maybe be 3 hours long, and then maybe one individual session that would be 1 hour long. So they'd have maybe 4 hours of treatment. And the idea here is that this is a little bit more of an intensive level of treatment. It gives people a little bit more therapy, but still allows them to remain at home rather than going to a hospital. So they could still work. They could do their treatment in the evenings or before after work. The next step up then would be what's called day treatment or partial hospitalization. And this would be people who go to treatment pretty much all day long, usually 5 days a week, Monday through Friday. And they go pretty much all day, but they don't stay overnight. So it's not a residential, it's not an inpatient program. But there would be a lot of educational groups, a lot of therapy groups, multiple meetings with a counselor, a therapist, a psychologist. And so that would be, day treatment or partial hospitalization. And then, of course, there would be inpatient treatment. This is when people actually go and stay in the hospital. Sometimes it's a hospital. Other times it would be sort of a non-medical rehabilitation center. Usually those stays are relatively short. They usually wouldn't last longer than 4 weeks. Some people need longer treatment than that, and so there are also long-term residential rehabilitation programs that can be 6 months or 9 months or even a year. And then outside of that continuum, there's also something called a halfway house. And for some people who have drug and alcohol problems, if they're coming out of inpatient or coming out of long-term residential, a halfway house would be a place where they would have more freedom than if they were inpatient. You know, inpatient, they're monitored all the time, around the clock. A halfway house would say, you can go out of the halfway house, you can go to work, you can go to school, but at the halfway house, there's going to be counselors, there are going to be people who are giving you drug tests. So there's going to be some level of accountability, but a little bit more freedom. And so again, this is for people who maybe have been through inpatient or long-term residential. They're not sure that they can make it on their own yet. They're not sure they can go back home yet. And so the halfway house is kind of what we call a step-down program that gets them a little bit closer, it gives them a little bit more freedom, but they're not completely on their own yet. I wanted to mention Alcoholics Anonymous. Alcoholics Anonymous is not a treatment program. It's actually a self-help program. And so by design, it's not run by professionals. It's run by other alcoholics. Many of you know something about AA. Some of you got a chance to go to an AA meeting at a homeless shelter in Klaipeda a year ago. But I wanted to tell you a little bit more about Alcoholics Anonymous because it's an interesting story, and it's used quite a bit by professional treatment providers, even though it's not professional treatment by itself. So Alcoholics Anonymous, or AA, was started in 1935 by two guys, Bill Wilson and Dr. Bob Smith. Bill Wilson was a stockbroker and a failed businessman who had a terrible alcohol problem and had lost his business and had lost a lot of his wealth due to his drinking. And in 1935, he had been sober for just a little bit of time. He had stopped drinking. And he had a history of, he'd stopped drinking for a while and then he'd go back to it. But this time in 1935, he actually was in a hospital in New York, in Charlestown Hospital in New York, and he had a spiritual experience. He talks about seeing a vision and experiencing God and never drinking again after this. So a few months after this, he was in Akron, Ohio on a business trip. And the business trip didn't go well, and he had very little money. You know, he thought this was going to be something that turned his life around, and the business venture didn't work out. And so he found himself in a hotel lobby, and he was standing outside the bar, just trying not to go into the bar and have a drink. And he saw a list of churches hanging on the wall, and he thought, well, maybe if I call the church, they'll help me. And he had this idea that if he could talk to another alcoholic, that might help him not to drink. And so he called a church and said, I'm Bill Wilson. I am an alcoholic, and I was wondering if you could help me. I was wondering if there's anybody in your church who's struggling with alcohol, and if perhaps I could talk to them. And so the person at the church put him in touch with another person who said, I've got just the person for you. And they got Bill Wilson together with a guy named Dr. Bob Smith, who was a surgeon, who also was an alcoholic. And together they came up with the idea that by helping each other to stay sober, they were also helping themselves. So this sort of goes back to when we talked about Yalom and his idea of altruism, that the group, in a group therapy session, when one group member helps another group member, it's good for both of them. Helping somebody is good for the helper as well as the help receiver. And so that was kind of the start of Alcoholics Anonymous, and it very quickly sort of spread and became popular. And over the next number of years, AA groups sprung up all over the place. And they've now actually spread across the world. We'll talk more about that in a little bit. But AA talks about being a spiritual, not religious program. So even though Bill Wilson and Bob Smith would have believed in the Christian God, they felt like they shouldn't push that on people. And so one of the things they do is they focus on God as we understood him. So they tell people, you need to have a higher power, somebody bigger than yourself that you believe in. It doesn't have to be an organized religion. And there's a thing in AA that says, you know, your God could be, or your higher power could be a rock or a doorknob or another person. You just need to stop focusing so much on yourself. Alcoholism has made you so selfish and so self-centered, and you've got to focus on something and submit to something bigger than yourself. And so AA would say it's spiritual, and that it focuses you on something kind of transcendent or bigger than yourself, but it doesn't have to be religious, although it could be. It doesn't have to be. Research has found that people attending AA meetings have an equal or even slightly better chance than people that have gone through professional treatment at remaining sober, remaining abstinent from drug and alcohol use. Another thing that's interesting about AA that I should mention is that AA made it popular to believe that alcoholism is a disease. And this started off when Bill Wilson was in the hospital. He had a doctor who told him, "You're allergic to alcohol and your body processes it differently." We know today that that's not the case, that alcoholism isn't an allergy, but a lot of people today would use this idea that alcoholism is a biopsychosocial spiritual disease, and they would say it has biological effects. We can see the difference in somebody's brain if they've used drugs or drank alcohol for a long time, and we do a PET scan. It's a psychological disease, and the book chapter that I had you read for this class talks about the psychological aspects of substance abuse disorders. There's something very reinforcing about the pleasure that people gain from, and the escape that people gain from substance use, and so that's the psychological aspect of the disease. There's also a social context here where we know that people often use about the same amount of alcohol or drugs as their peer group. And finally, there's a spiritual component. AA says we think this is a spiritual disease. We think that the founders of Alcoholics Anonymous said that alcoholics have a God-shaped hole in their life, and they're trying to fill it with alcohol. They're trying to pour alcohol into that hole, and they're never going to be okay until they actually surrender to God. Of course, they would say it's God as we understand Him. It's a higher power, but they say there's something spiritual about this disease. So this idea that alcoholism and that drug addiction is a disease, this is very popular in the U.S. right now. It's not quite so accepted in other parts of the world, although it's popular there as well, but it's very popular in the U.S. And there's some problems with the disease concept. One of the problems is that for a lot of diseases like cancer, diabetes, we have physiological markers. We don't have those with alcoholism and drug addiction. We can see the damage that alcohol and drug do to the brain and to the other parts of the body, but that really seems to be trauma, not necessarily biological or physiological markers of the disease itself. It doesn't kind of point to the origins or the etiology of the disease. So a lot of people buy into the disease model. Some people are a little bit more skeptical of it, and it can be sort of controversial sometimes, but very highly accepted in the U.S. Here's the 12 steps of Alcoholics Anonymous, and I want to spend a lot of time on this, but I wanted to just read through these. So the first step is that people admit that they're powerless over alcohol, that their lives become unmanageable. The second step is this belief that a power greater than ourselves could restore us to sanity. The third step is making a decision to turn our will and our lives over to the care of God as we understood Him. So notice that language, power greater than ourselves, God as we understood Him. Again, sort of a generic, broad understanding of God. The fourth step is to make a searching and fearless moral inventory. And this is really a list of all the things that people can remember that they've done wrong while they were under the influence of drugs and alcohol. And under the influence, I don't just mean intoxicated, but while they were living in their addiction. The fifth step is to admit to God, to oneself, and to another human being the exact nature of the wrongs. And so people actually go over that inventory from step 4, and they tell somebody else all the things they've done wrong, as well as telling God. Number 6 and number 7 would be become ready to have God remove these defects of character, these things you've done wrong, and then asking God in step 7 to remove those shortcomings. Number 8 and 9 go together. 8 is making a list of the people that have been harmed while in the addiction. And then number 9 is making amends to those people. That means really making it right. So if you've stolen something from somebody while you're drunk, you go to them, admit that you stole something, you pay them back. The only time that you wouldn't do something like that AA would say you shouldn't do that, is if you're going to hurt somebody else by making amends. So if you cheated on somebody else's spouse, or with somebody else's spouse, and you go to that spouse and say, hey, I had an affair with your wife, that might mess up their marriage. Maybe they've moved past that. You might actually cause more problems than you solve. And so AA would say you should probably not make amends in that case. Number 10 is that you continue that process of taking inventory of your life and admitting it and making amends when you're wrong. Number 11 is that you use prayer and meditation to continue to develop your contact with God. And then number 12 is this idea that you try to carry the message of AA to other alcoholics. And this is where this idea in Alcoholics Anonymous of sponsorship comes in. People who are doing the 12 steps often become a sponsor for somebody who is newer to sobriety. And so somebody who's on that 12th step has often been sober for a while. It takes a while to go through each of these steps. And so they're at a point where then they can sort of be a mentor, or AA says a sponsor, to somebody who's newer, who's trying to stop drinking. So that's the 12 steps. These 12 steps have been adopted for other groups, groups like our Narcotics Anonymous that help people who are abusing narcotics or opioid drugs. They're called NA instead of AA. Or Sex and Love Anonymous, which it would be a group that works with sex and love addiction. There's also a Gambling Anonymous, a Marijuana Anonymous. So different groups have taken different problems that sort of control people's lives and used those 12 steps to try to help with those problems as well. There's some controversy in the U.S. over the AA because courts often require people to attend AA meetings. In the U.S., we have these laws that say that the government can't force somebody to be involved in any particular religion. And some people say that because AA requires people to believe in a God, that it's religious. And so there have been some courts, some higher courts in the U.S. that have actually said, yeah, it's not really legal to do that. But it still happens a lot because a lot of the people who are forced to go to the meetings, either the meetings help them, or they're people who are just trying to stay out of jail, and they know that if they fight their probation officer or the judge, if they lose, they might just cause more problems for themselves. And so a lot of people just kind of go to these meetings, and some of them don't really get much out of them. They just go because they're going to go to jail if they don't, because a judge or a probation officer has told them they have to go. And so a lot of times the AA people, if you talk to people in AA in the U.S., they'll tell you, yeah, there's some guys that come in and sit in the back and never say anything, and then they just want to sign their papers so the judge knows that they're here. AA doesn't really mind that too much, though. They feel like at least those people are getting in the door, and maybe eventually they'll kind of catch on and become part of the program. It's pretty interesting because AA is now spread all across the world, and in fact, I know for sure that there are AA meetings in Lithuania because you guys have gone to a few, or you may have. A few years ago or a year ago, there was a chance for some of you to go to an AA meeting at the homeless shelter in downtown Klaipėda. And there's also an annual conference in Riga every year for Alcoholics Anonymous, and so that's another way that it's kind of spread, would be where all kinds of different AA groups come together at these larger conferences. They have them in the U.S., they have them in other parts of the world, but I've heard about them in Riga as well. So some of this is spread into Europe and the eastern parts of Europe. Okay, another treatment model. Again, AA isn't exactly treatment, but it's often used in conjunction with treatment. Counselors will often tell people, okay, as part of your counseling here, we'll do the professional counseling, we'll do the professional psychology. We still think you should go to AA on the evenings and on the weekends. So a similar treatment model to AA is what's called the Minnesota model of treatment. This developed out of AA. It's professional psychologists and counselors who use the 12 steps of AA. But AA doesn't officially endorse the Minnesota model. It's just that the Minnesota model kind of took AA steps and uses them in a professional setting. But one of AA's traditions is that it doesn't endorse any particular kind of treatment, and that it's non-professional itself. So if you've heard anything about 28-day rehab treatment, which is popular in the U.S., there was even a movie with Sandra Bullock a number of years ago called 28 Days, which was about a person who goes to a rehab. That 28-day or that 4-week rehabilitation model, that actually traces back to the Minnesota model, which developed out of AA. Another treatment model is what's called relapse prevention, and this is a cognitive behavioral therapy based model. And so the idea here is that the therapist, the psychologist, tries to teach clients to identify triggers. And these would be people, places, things, emotions, thoughts, anything that leads that person to want to use drugs. And then they try to learn to cope with those triggers. So, for example, if there are certain emotional states, some people drink when they're very happy, other people drink when they're down. And so one of the things that a cognitive behavioral therapist would do is try to help people do two things. One, identify what their triggers are, maybe it's positive emotional states, and then two, to be able to cope with positive emotional states without using drugs. So to put something else in the place of drugs there, whether it's learning to celebrate positive emotional states in a new way would be an example of that. Another thing that might happen in a relapse prevention program would be that refusal skills training. teaching people how to say no to drugs. So if you're a long-time drug user, probably most of your friends are drug users, you get out of rehab, they see you on the street, they come up and say, hey, let's go, let's get high, we've got some really good stuff. One of the things that they would teach you in a relapse prevention program would be something like the 30-second rule, where they'd say, if you talk to that person for more than 30 seconds, you're likely to do what they want you to do. And this doesn't just apply for drugs. Sometimes you'll notice if somebody's trying to sell you something, at least in the US, they often get you talking, whether it's a salesman in a store or somebody on the telephone, they'll get you talking about your day, about how you're doing. One of the things that we found in research is that if you talk to that person for more than about 30 seconds, you're kind of hooked in and you have a greater likelihood of doing what they want you to do, whether that's buying something, whether that's using drugs. So one of the things we do in relapse prevention is try to teach people to quickly get out of conversations, to be firm, to make a joke, to do something to just kind of end that conversation and get away. The Matrix program, which is described in an article by Rawson et al. That I asked you to read for this week, an article on the Matrix program, is an example of a program that uses a relapse prevention approach for the treatment of cocaine addiction and amphetamine addiction, stimulant addiction. Another treatment would be psychopharmacology, the use of medication to treat substance abuse. There's a couple different types of medications that are used. One would be what's called antagonist medication. This is medication that blocks the effects of drugs or alcohol. So an example of this would be naltrexone, which is a medication that blocks the effects of alcohol and opioids, things like heroin. Another type of medication that's used is what's called aversive medication. This is medication that if you take this medication and then you use your drug, it causes unpleasant side effects. It makes you very sick, throwing up, feeling terrible. So an example of this would be disulfiram, which in the US is called Antabuse. That's its trade name. If you take Antabuse and then you drink alcohol, you're going to get very, very sick. Antabuse is used in other parts of the world, and in fact in the former Soviet Union, and I know this is the case in Russia, doctors have a history of giving patients disulfiram and telling them, if you drink while you're on this, you're going to die, which really isn't true. They're just trying to kind of scare them away from drinking. And the truth is you might sort of wish you died if you drank after you've taken this, because you're going to be throwing up uncontrollably. You're going to feel terrible for a while. So that's aversive medication. Another type of psychopharmacological intervention would be agonist therapy. And this is also called substitution treatment. An agonist is a medication that acts in a similar way to the drug of choice, but it has usually a less euphoric high, a less extreme high, and a more level profile. So if you take something like heroin, you get very high, and then you drop off very quickly, and you feel sick and you want more heroin. The agonist medication that's used in place of heroin, things like Suboxone or methadone, that actually gives you somewhat of a high, but a less extreme high, and it doesn't drop you off so quickly. So the idea is that you could sort of maintain people. You could give them a low dose of methadone or Suboxone, and that would keep them from using heroin. They might be able to work, they might be able to have a more normal life while they're on these agonist drugs. These drugs are also used in another way, and that's for detoxification. If somebody comes in on heroin and they stop using heroin, all of a sudden they're going to need to be detoxed or they're going to get very sick. And so we might use something like methadone, which is the same, it has the same core drug as heroin, but it's a different formulation. And that drug might be used because it's a little bit safer, less extreme profile. It might be used to sort of wean that person off of the heroin. So I mentioned methadone. Suboxone is an interesting drug. It's actually a combination of a couple other drugs. It's buprenorphine, which is a partial agonist, which for heroin and for other narcotics, which means that it doesn't completely give the same high. It doesn't completely, it doesn't have that extreme profile, but it's enough that the person doesn't get sick. They don't go through withdrawal, so it's a partial agonist. And then this drug also has an antagonist in it, naloxone, which means if you take too much of it or if you inject it, it actually is supposed to keep it from that drug from getting you high the way that heroin would. So it's got both agonist and antagonist properties. This agonist substitution is one of the one of the techniques used in something called harm reduction, which I'll talk about in a moment. But it's sort of controversial. Some people say, why wouldn't we want to give people agonist substitution? It lets them have a normal life. It helps families stay together. They can work. They can, not get diseases. They're not going to be injecting anymore. They're going to be monitored by doctors and nurses while they're taking the drug. And there's a lot of good that comes out of it. Other people say, why would we treat drug addiction by, giving people more drugs? So some places in the world this is very common. Other places it's illegal, and it just kind of varies by place. As of the last time I checked, it was illegal in Russia, but was actually used quite a bit in some other parts of the former Soviet Union, including Lithuania and Poland. Actually, sorry, Poland was never part of the Soviet Union, but is part of the kind of the same region that Lithuania is in. So I mentioned harm reduction a moment ago, and harm reduction is sort of like treatment, but it's more of a public health model rather than an individual treatment. So harm reduction says we should focus on reducing the harm that drug and alcohol abuse causes to individuals and society. So instead of saying we should try to get people to stop using drugs and alcohol, now harm reduction people think it'd be great if people stopped using, most of them do, but what they say is we're not going to make that the only reasonable goal. We're going to say if people use drugs in a safer way, if people use drugs in a lower amount, any sort of change like that is positive, and it reduces the harm caused by the drugs. So this approach is used in many parts of East and Central Europe, and in the former Soviet Union, but not in Russia. And so it's kind of becoming increasingly common. In fact, in Lithuania, harm reduction started in Klaipėda. Some of the things that happen as part of harm reduction would be clean needles, or what's called needle exchange programs. So the idea is that somebody that's shooting heroin with a needle, injecting heroin with a needle, as I mentioned earlier, they're at much higher risk for getting HIV/AIDS, hepatitis B and C, other communicable diseases. Then the thought here is if we can get them to use clean needles by giving them clean needles for free, these diseases aren't going to spread in nearly the same amounts. Because what often happens is then the person gets the disease through the drug use, but they might spread it through sexual contact. And so we can keep a whole lot of people safer if that person's using clean needles. That's the theory behind harm reduction. I've already mentioned agonist substitution or agonist maintenance programs. They're often a part of harm reduction. Safe injection sites would be another place. It's instead of having people go into back alleys and abandoned houses where they're filthy and they're dirty and they get infections, let's give them safe, medically monitored injection sites where they can have alcohol wipes to kind of clean the injection area, where they can have clean needles, and that this is going to lead to safer drug use. And there's also often a number of other services for users at these centers, or sometimes there's even outreach services where they're going out, they're trying to get people better health care, food, other necessities, things like that. Okay, that's it for substance abuse treatment. Hopefully that's been helpful in helping you understand what psychologists who work in the field of substance abuse treatment might do, some of the different approaches. Be sure to do the reading and to take the quiz. Okay, talk to you again soon. Bye now.